So in terms of the frontline therapies we have for CLL, I really think about them in terms of two buckets, right? So the first of which being the BTK inhibitors. We've had ibrutinib around the longest, followed by acalabrutinib, and more recently in the past year, the approval of zanubrutinib. Now, certainly there are varying rates of side effects amongst each of these agents, but I think as a whole, the class effect we do see is cardiac arrhythmias and most specifically atrial fibrillation. Those rates are highest with ibrutinib, followed by acalabrutinib. Lowest reported rates of atrial fibrillation are with zanubrutinib. So certainly I think for anybody who's taking care of a patient with CLL who is on any of these BTK inhibitors, just having that low threshold for further workup, if they have any symptoms that are concerning to you about, say, palpitations, racing heart, chest pain, those sorts of things. So cardiac events are important. Hypertension is something we can see with these agents. The rates of hypertension are pretty similar in comparison when you look at ibrutinib and zanubrutinib in the Alpine trial. You do see slightly lower rates of hypertension with acalabrutinib compared to ibrutinib in the Elevate-RR trial. So helping coach patients on diet and exercise, optimizing their antihypertensive regimen. You do want to think about avoiding antihypertensives that are things like carvedilol or diltiazem because they do have some interactions in the CYP3A pathway. The big things I think about with respect to, and one other thing that's really important about BTK inhibitors for nurses, APPs, anybody who's caring for patients on these agents, they reversibly inhibit platelet function. So that means that patients are at an increased risk for bruising and bleeding. So any procedure they have, not quite any, but most procedures they have, you do need to have them hold it for about 3 to 7 days before and after those procedures. And so 3 days before and after would be things like colonoscopies. If they're having a Mohs surgery for a skin cancer removal, then maybe 5 days before and after. And then certainly if it's a larger surgery like a total hip replacement, a total knee, 7 days before and after. With respect to the time-limited venetoclax-based regimens, I think the key pieces here are upfront, that monitoring and prevention of tumor lysis syndrome is critical. That's why we do the dose escalation, weekly dose ramp up, making sure people stay hydrated, making sure they're taking allopurinol, making sure that they're having appropriate lab monitoring per package insert at each of those steps is all important in terms of decreasing that risk. The other main side effect we can see with venetoclax, in addition to the risk for tumor lysis syndrome, which we don't actually see much of because of all of these steps that we've taken, is both stomach upset and loose stools. A couple of things that can help with that, taking it with food, taking it in the evening instead of the morning, and things like Imodium as needed, certainly making sure they don't have an infectious cause of diarrhea. And then finally, neutropenia is the other thing that I would think about in that bucket. So infection risk, neutropenia, do they need growth factor support? Those are some of the key features that I would pull out from a venetoclax-based regimen.